This is Dr. Gardner with some major points about cardiovascular, which will include hypertension, heart failure, a little on congestive heart failure, angina, and hyperlipidemia. So these are the objectives, and I am not going to read you all of the objectives because they are in your unit. So let's talk a little bit about antihypertensive drugs and hypertension. So to get a good understanding, and this is information you should already know, is hypertension is the silent killer. Heart disease remains the leading cause of death for men, women, and people of most racial and ethnic groups in the United States. That hasn't changed in years. One person dies every 33 seconds from cardiovascular disease. That is like 1 in 5 deaths in 2021. And it has a price tag of about $239.9 billion each year in medical costs. So what puts a patient at risk? Well, diabetes, an unhealthy diet, being overweight or obese, lack of physical activity, which is lack of exercise, and excessive alcohol use. So the types of hypertension would be secondary, which is due to a cause such as primary hyperaldosteronism or maybe renal vascular stenosis. Secondary hypertension can be cured if you rectify the cause. What's causing it? Fix the cause, fix the hypertension. Now, essential hypertension, that cause is unknown, but it is related to, again, obesity, a sedentary life, diets high in sodium and fats. Tobacco users are said to be more prone to essential hypertension. This one can only be controlled, not cured. So 90 to 95% of patients have persistent hypertension. That is, origin of the hypertension is unknown, but they do have the predisposing factors. Now, there are some people who it's hereditary and they don't have any of these factors, and you're probably thinking, well, Dr. Gardner, I know somebody who's beanpole thin, doesn't smoke, jogs every day, they're fine, but they have hypertension. Well, they may have her because of a hereditary factor. So there you go. Positive family history, insulin resistant, age, sex, um, or maybe a defect of the local vasomotor regulation. There's a little joke over there for y'all. Secondary hypertension is secondary to some kind of distinct disease like sleep apnea. People with sleep apnea are more prone to have hypertension. Chronic kidney disease, thyroid, parathyroid, um, drug-induced or related causes. There's several different causes that can cause secondary hypertension. So there's the classification of blood pressure and consequences of hypertension. What are your goals of therapy? Are you trying to cure it or are you trying to control it? Are you going to teach lifestyle modifications? And when do you do pharmacologic treatment to regulate the blood pressure? When do you give those antihypertensive meds? There is an algorithm, and you guys have it. You have access to it in Moodle. You also have the JNC8. Go over the JNC8. You will see the JNC8 again. So go over the JNC8. So this is just a review of the JNC8 and the recommendations. I'm not going to read them all to you. You should have access to the JNC8. But these are the 9 recommendations, just a brief overview of them. And I'll leave this slide up for a minute so y'all can take a look at it. So target organs: heart, kidneys, veins, eyes, the brain. So you can have coronary heart disease, congestive heart failure, left ventricular hypertrophy. So when we talk about lifestyle modifications, that's reducing to a normal weight, a normal BMI. Dash eating, and I'll have a little bit about that dash eating in a second. But that can reduce the blood pressure by 8 to 14 milligrams of mercury. Um, Dietary sodium restriction, regular exercise, reducing alcohol consumption. And when we say physical exercise, we don't mean walking your dog while you're riding in your car. The DASH diet emphasizes fruits, veggies, low-fat dairy foods, and reduced sodium. It includes whole grains, poultry, fish, and nuts, reduced amounts of red meat, sugar, and fat, and cholesterol. So let's go over some of the medications. At least I'll kind of go over some. You guys have a lot of medications to review. Make sure you go over those slides. Make sure you look in your book, and also make sure you look at the notes. So I'm going to give you some major points to kind of help you put it all together, but this is not everything. Beta blockers. Um, they're used in the treatment of angina because it increases the heart in diastole and it lowers cardiac output. So they may not be a good choice for CHF patients. In the classifications, there's non-selective, cardioselective, there's the beta blockers with intrinsic sympathomimetic activity, and there's also the 3rd generation. So some of the non-selective is propranolol, and that decreases the heart rate. And it also interacts with verapamil, diltiazem, and digitalis. That's propranolol. That's why you see the asterisk. So caution when using it because it could possibly cause an AV block. Some of the B1 selectives are metoprolol, atenolol, and bisoprolol. You want to be very careful dosing these in diabetics and patients with asthma. In diabetics, it may mask hypoglycemia. And you also have some of the intrinsic, and these are used in Raynaud's. Calcium channel blockers. What is that? Verapamil, diltiazem, Procardia, which is also nifedipine, which lowers the PVR, causes vasodilation and lowers blood pressure. Very good to use in African Americans or Black people. Calcium channel blockers is used in the treatment of stable angina. It blocks voltage dependent. It causes relaxation of the smooth muscle and reduces peripheral vascular resistance, causing a reduction in blood pressure. Again, nifedipine is used to treat hypertension and angina. You have your angiotensin converting enzyme inhibitors, which are also ACEs. And those are the prils, easy to remember. Lisinopril, enalapril, captopril. If it's a pril, it is probably an ACE. So what do ACEs do? They block the transformation of angiotensin 1 into angiotensin 2. It decreases the PVR, which causes a decreased blood pressure, and it may increase the life expectancy in patients with heart failure. But some of the effects of it is that you may have a skin rash, funny taste in the mouth, cough, or hyperkalemia. With that cough, if you have put a African American patient on an ACE and they start to cough, or if you put anybody on an ACE and they start to cough, you're going to want to take them off. You don't want your patient to end up with angioedema. Also, you want to watch their potassium levels when they're taking ACEs. So diuretics. Diuretics are used as initial therapy alone or in combination with drugs from other groups. Some of the adverse effects is renin secretion. There's different types. There's thiazides and loops. And it is the first line treatment for hypertension, but it's so underutilized. So way back when I took pharmacology and when I started practicing, hydrochlorothiazide was always the go-to. Always the go-to. And then you have to remember, it may be the go-to, but think about your patient's situation. So, would you give a diuretic to a man with high blood pressure who's working outside daily on a roof? Think about that. Um, Diuretics also enhance the antihypertensive efficacy of multi-drug regimens, and they can be useful in achieving blood pressure control, and they're much more affordable than other antihypertensive drugs. So I talked about the loop diuretics. They cause a decrease in pulmonary venous pressure, which reduces pulmonary edema. And there's some examples of the loop diuretics. So loop diuretics are used in the treatment of congestive heart failure, nephrotic syndrome, or cirrhosis, and in the management of fluid overload. You want to tell your patients to take these medications in the morning to avoid nocturia. We'll go over nitrites, which is nitroglycerin. Also Imdur, Isobid, Bidil. They're all different examples of nitrates. So what are nitrates used for? They're used to decrease the myocardial oxygen demand, and it decreases the preload, which reduces the work of reduces the work of the heart. So it's used to decrease the myocardial oxygen demand, and it decreases the preload, which reduces the work of the heart. So what do you want to tell your patients who are taking nitrites or who may be helping them with nitrites? If they're using topical nitrites, wear gloves, because this medication can cause headaches. It can go through the fingertips of someone who's not using it and cause headaches. It may cause low blood pressure and a higher heart rate. And if they've taken 3 doses, they need to call 911. Do not take Viagra if they're taking nitrates. Also, the first dose may cause a headache, so you want to let your patients know that. So I'll talk a little bit about drug therapy for hypercholesterolemia and dyslipidemia. So there's different drug classes used in this therapy, which is statins, nicotinic acid, bile acid sequestrants, fibric acid derivatives, and inhibitors of cholesterol absorption. Your statins: simvastatin, rosuvastatin, pravastatin, atorvastatin, lovastatin. Get it? Statins. Statins. They all have statins in their names. The mechanism of action is to prevent or slow down liver synthesis of cholesterol. This Statins prevent the liver from making cholesterol. It increases the synthesis of low-density lipoprotein receptors, which pulls LDL out of the blood, resulting in lower LDL levels. Some of the adverse effects of statins would be liver toxicity. So all statins induce dose-related increases in the hepatic transaminase. Did I say that right? And it's contraindicated in patients with active liver disease. So take extra caution with patients who drink heavy amounts of alcohol, and patients should not take statins with grapefruit juice. Pregnancy that's not yet established if it's safe, so use caution when prescribing, and also use caution in prescribing statins to women who are on oral contraceptives. With children, atorvastatin, lovastatin, and simvastatin may be used in kids older than 11, and pravastatin can be used in kids older than 8. So statins require active monitoring, and you're going to monitor their labs routinely when prescribing statins. Now think about this. Which labs are you going to monitor and why? Okay, you've got all the answers you need right here on the slide. Which labs? It's pretty simple. Nicotinic acid, which is niacin, it is one of the best agents available to increase HDL. It also decreases triglycerides by 35 to 45%, and it reduces LDL levels by 20 to 30%. So if they want to use an over-the-counter formulation, they can get the crystalline niacin. That one they may tolerate it better if they start in low doses. The sustained release, that's a continuous release over about 6 to 8 hours after ingestion. On the extended release, they need a prescription for that one, so they would have to get that from you, and it's a little bit less hepatotoxic. But some of the main complaints about niacin, it's a good drug, but it causes dyspepsia, especially if they've drank coffee, tea, or alcohol. It also causes an intense flushing or pruritus. So they don't want to take it because the flushing is just horrible. This may also increase uric acid and reactivate gout in diabetic patients. Bile acid sequestrants, that is one of the oldest and safest of the lipid-lowering agents. They take that when you dissolve it in water and juice and meals at bedtime, or they may take it 2 times a day with a meal. Bile acid sequestrants bind directly and may interfere with absorption of many drugs, including statins. It's recommended for patients 11 to 20 years old, and it reduces the amount of cholesterol that's stored in adipose tissue. Oh, and that is it. Okay, that's a quick one. So that is another major points.